Greetings of the day, dear students. This session is for BSc Nursing second year students. The topic is hyperparathyroidism. So, as the name is suggesting, hyperparathyroidism, it means there are abnormally high parathyroid hormone levels in the blood, and this is because the parathyroid gland's activity is increased. So, we can define hyperparathyroidism as abnormally high parathyroid hormone levels in the blood due to overactivity of the parathyroid glands. So basically in the hyperparathyroidism HPT, there are increased levels of PTH hormone. We can classify this as primary, secondary and the tertiary. In the primary hyperparathyroidism, so there is an hyperfunction of the parathyroid gland. So there are the disorders of parathyroid glands which are causing the hyperparathyroidism. For example, any parathyroid adenoma or hyperplasia or the carcinoma. This is a very rare case that parathyroid carcinoma cause the primary hyperparathyroidism. Then in the second and the tertiary hyperparathyroidism, the most common is the primary hyperparathyroidism. So the lifetime incidence is 1 by 80. Females are more prone, more risky for having this disease. 3:1 ratio is there. Then in the most cases occur after the age of 50 and the prevalence is approximately 0.1 to 0.5%. So we discuss about the primary hyperparathyroidism, then secondary. In the secondary, there are decreased levels of calcium in the blood. So I hope all of you must be knowing that if there are decreased plasma calcium levels, the PTH will be increased, and then it will stimulate the bone to break down the minerals which are calcium and the phosphate. So there will be increased levels of calcium and the phosphate. Also, it also enables to activate the kidneys enzyme which is helpful for the formation of the active vitamin D hormone, and this also stimulate small intestine to increase the absorption of calcium and phosphorus. So what's happening in the secondary hyperparathyroidism, there is decreased calcium levels, right? When there are decreased calcium levels, this will stimulate the parathyroid hormones to increase, because the function of the parathyroid hormone is to increase the blood calcium level. So why it occurs? Because there is a deficiency of vitamin D or the person is having the kidney failure. So this is the general mechanism. Like for example, in the skin you have this 7-dehydrocholesterol, right? And the sun gives the UV rays. When under the influence of these UV rays, the 7-dehydrocholesterol will be converted into the cholecalciferol, that is vitamin D3. Then the liver will convert this vitamin D3 into the 25 hydroxy vitamin D3, and then kidney will convert this 25 hydroxy vitamin D3 to the 125 dihydroxy vitamin D3. So this is the active vitamin D, and this will enable uh, to stimulate the small intestine to increase the absorption of calcium and phosphorus. Also in the kidneys only, it will stimulate the reabsorption of calcium from the proximal convoluted tubules. So we can say that there is a requirement of the kidneys and this vitamin D, right, for the calcium, for the maintenance of calcium and phosphorus in our blood. So that's why if there are decreased calcium levels in the blood, the PTH will be increased, and this is caused in the secondary hyperparathyroidism. Then the tertiary, for example, the person was having the secondary hyperparathyroidism for a longer period of time. So because it is chronic in nature and it is not resolved, it is not treated, so there will be the hyperplasia of the parathyroid glands. And because it is a chronic uh, condition, it has been for so long that there will be parathyroid gland will be lost to have they will have no any activation for the serum calcium levels. Means it doesn't matter to parathyroid gland whether the calcium levels are normal, now they have to reduce the secretion. No, there will be unregulated or autonomous parathyroid function. So even though the calcium levels are improved, they are in within the normal level, but the parathyroid gland is unregulated, it is autonomous, and it will secrete on this it will continue to secrete this PTH. So this happens in the tertiary hyperparathyroidism. Now pathophysiology. So as I told you, because there are reduced blood calcium levels, there will be increased secretion of PTH. Now what will happen, this PTH will be, how it will affect, it will affect the bone and the kidneys both. This PTH will increase the bone resorption, and because it is increasing bone resorption, there will be increased release of calcium and phosphate from the bone, and then therefore increased calcium levels will be in the plasma, right? Then on the kidneys, this is important. If PTH on the bone, PTH effect is to increase the calcium level, but on the kidneys it will cause the increased phosphate excretion, that is phosphaturia. So the most important thing to remember here is that in the primary hyperparathyroidism, there will be increased calcium level but decreased phosphate levels, right? Now in the secondary, one of the most common causes is CKD only. So if there is CKD, the person will have impaired renal phosphate excretion, there will be increased phosphate blood levels, and if the phosphate levels are increased, there will be PTH secretion will be increased, right? So in the primary, the PTH, the phosphate levels were decreased because phosphaturia was happening. But in the secondary, there are increased phosphate blood levels. Similarly, if there is CKD, the person is having chronic kidney disease, there will be no any formation of vitamin D, because we already discussed what is the role of kidney in the formation of active vitamin D, right? So if there is no any active vitamin D, there will be no any intestinal calcium resorption. So decreased renal calcium resorption, so there will be hypocalcemia. And if there is hypocalcemia, there will be increased PTH. So in this way, secondary hyperparathyroidism occur. Now sign and symptoms. In the primary, majority of patients are asymptomatic, and in the cardiovascular, because there is hypercalcemia is occurring, and hyperphosphatemia, this is occurring, hyperphosphatemia is occurring in the secondary only, in the secondary hyperparathyroidism. So it will cause the accumulation of salts, these calcium and phosphate, in the heart muscles and the arteries, and this causes left ventricular hypertrophy also, and it also reduces the flexibility of the arteries. In the kidneys, there are chances of formation of renal stones, especially of calcium oxalate and the phosphate. Nephrocalcinosis, in which there is deposition of calcium in the renal tubules. Polyuria, polydipsia also occur. In the musculoskeletal system, there will be bone, muscle and joint pain. There will be pseudo gout. There will be osteitis fibrosa cystica, cyst like brain tumor. In the skull, there will be granular decalcification, that is salt and papa skull. So what is that? Pseudo gout. Gout is basically accumulation of uric acid in the joints, and so it is a arthritis only. But here, because of the hyperparathyroidism, there is a deposition of calcium pyrophosphate dihydrate crystals in the hyaline or the fibrocartilage. So this is also causing the arthritis, but the but there is a deposition of calcium pyrophosphate dihydride crystals, not the uric acid. So that's why it is called pseudo gout. Then osteoarthritis fibrosa cystica, because we know that um, in the case of hypocalcemia, there is resorption of calcium from the bone, so there is a loss of bone mass, weakening of the bones, and their calcified supporting structures are replaced by the fibrous tissue, right? So these bones will have more fibrous tissue, less calcium, and then there is a formation of cyst like brown tumor also in and around the bone. This is the salt and the pepper appearance of the skull, and it is occurring because there is a degranular calcification, right? Sorry, granular decalcification. Then digestive tract, there is a lack of appetite which is causing the weight loss, nausea, constipation, gastric or duodenal ulcers, and pancreatitis. Because of hypercalcemia only, there is increased gastric acid, so there are increased chances of gastric or the duodenal ulcer. Then psychological symptoms like depression, fatigue, anxiety, and the sleep disorders. Then in the secondary hyperparathyroidism, most commonly related with the underlying cause, for example, vitamin D deficiency or the chronic kidney disease. So there is bone pain and increased risk of fractures. Now diagnosis, as we already discussed in the primary, there will be increased serum calcium but decreased phosphate levels. Alkaline phosphatase will also increase, parathyroid hormone will also increase. In the secondary also, PTH will be increased, ALP will be increased, phosphate will be increased, and the calcium will be decreased. Then ultrasound or nuclear imaging by using this technetium 99M system EB scan is performed. This technetium M scan is done by the IV administration of this radioisotope only technetium. Then gamma camera is used, uh, imaging is done. So basically the parathyroid gland will take up this technetium, and then uh, it it will be helpful to know whether there are abnormal location of this parathyroid gland present or not, or adenoma, there is parathyroid adenoma is present or not, because the adenoma will take up this technetium more. Then treatment is surgical and the non-surgical. In the surgical, the surgery is performed of the patients who are symptomatic or asymptomatic patients but who have one of the following, like age is less than 50 years, serum calcium level more than 1 milligram per deciliter higher than the normal upper limit. Mostly the normal serum levels are serum calcium levels are 8.6 to 10.3 milligram per deciliter. So if they are more than 11.3 milligram per deciliter, impaired renal function, that is estimated GFR is less than 60 ml per minute, there is increased calcium excretion in combination with an increased risk for nephrolithiasis like 400 milligram per day. Then evidence of any nephrolithiasis, nephrocalcinosis via imaging, and the bone mineral density is reduced. Now this surgery is performed in order to remove the parathyroid gland only. So there may be salivary adenoma, so remove only that gland only, which is called parathyroidectomy. Then if there is hypoplasia, remove all the 4 glands, and if there is carcinoma, then resect the tumor. Ipsilateral means one-sided thyroid lobe, in which side there is parathyroid which is affected. Then enlarged lymph nodes also removed. Then in the non-surgical, administer the calcium mimetics, means they will increase the parathyroid, they will decrease the parathyroid hormone levels. Then in patients with the osteoporosis, bisphosphonates are given like risedronate and alendronate. What is their function? They will prevent and treat the bone loss, right? Then avoid lithium diuretics and thiazide diuretics. Then in the secondary, treat the underlying condition, that is chronic kidney disease, vitamin D deficiency. Treat the hyperphosphatemia by reducing the phosphate in the diet, like no soft cheese, nuts. and also use phosphate binders like calcium acetate, carbonate, sevelamer, lanthanum. And if there is vitamin D deficiency, provide ergocalciferol, which is vitamin D3 only. So this can be done. In the tertiary hyperparathyroidism, the treatment is similar to the primary one. So basically in the hyperparathyroidism, there is increased PTH levels, right? The parathyroid hormone is increased. So if there is increased PTH, there will be increased calcium levels in the blood. So the person will have hypercalcemia. It can be primary, secondary and tertiary. The most common causes in the primary are the parathyroid adenoma, hyperplasia, and more rarely it is carcinoma. In the secondary, the person may have chronic kidney disease or the vitamin D deficiency, right? And if the secondary hyperparathyroidism is not resolved for a specified period of time, there may be autonomous unregulated parathyroid hormone leading to the hyperparathyroidism. So most commonly, the signs and symptoms are related to the hypercalcemia only. There will be deposition of calcium, phosphate, and in the heart, in the arteries. There will be this will affect the musculoskeletal system, cardiovascular system. The person may GI system. The person, right? And the diagnosis is usually done by the laboratory, then imaging, ultrasound, and the nuclear imaging. And treatment most commonly focus on the cause, right? If it is adenoma, if it is carcinoma, then surgery is preferred in symptomatic patients. And there may be drugs which reduce the parathyroid hormone and which bind the phosphates. So this is all about the hyperparathyroidism. I hope you have understood this session. If you have any doubts, you can ask. Thank you.